And what about the two that are on label? How do you choose between those two?
To some degree, I look at different lesions. There are certain lesions that I might treat with one agent. There are certain lesions that I might treat with another agent. I think everybody has their own view and comfort about which agent they feel more comfortable with. And so for me, it's a very individual decision.
So 2 thoughts on that. It's nice to have options. There's a reason that we have more than one blood pressure medication. Not everybody responds the same to a given medication. It's nice to be able to switch around medications, and some people do respond better to one drug than another. I think the biggest thorn in our side as retina specialists from a payer perspective is when we are forced to use one medication over the others. That is extremely frustrating, especially for patients that are suboptimal responders and we cannot switch them off.
So let me venture a wild guess. The one that's cheapest is the one that's off-label, bevacizumab. Is that right?
Correct.
And are you guys going to require they try that first?
Well, actually, in all fairness, one of the important things from a payer standpoint, not just for this subject, but in the broader sense of things, FDA product label has an incredibly important role for us.
Okay.
And so actually for a while, up until recently, we only had FDA-approved products on as an option.
Okay.
We have since expanded that, but for initially, because it has so many other implications to other conditions, FDA product endorsement of a particular item is really important.
Okay. But again, bevacizumab, unless I'm wrong, bevacizumab is a lot cheaper.
Oh, it's a fraction of the cost.
So where does that leave you?
Anywhere from 40 to 50 times the cost of the approved agents.
Well, that's a dramatic difference.
It's a profound difference.
Do you
if
ask
it was
folks-
double the cost or 3 times the cost, we probably wouldn't have so much discussion. But we're talking about 40 to 50 times difference.
Let's role play for a second. And I'll be, because I'm going to spare you guys the fight just for a moment, I'll be the retinal specialist. And I'm going to call you up and I'm going to say, hello, this requires this drug or that drug. And you're going to say, that's 40 times too much. Why don't you try bevacizumab first? Is that what you're going to say?
Probably. But the
And I'm
question
going to
is,
say,
would
but it
we-
doesn't work as well.
But the question is, would we stick to that position if the physician says, no, I really do believe that the 40 to 50 times more expensive product is the one that my patient needs. And if that's what the physician says, I would say almost all the time that would be approved.
Can I turn you loose on this?
I want you to cover my practice, because that's not my experience.
Please,
Yeah,
go ahead.
well, I mean, that's what I do every day is I handle appeals for
I guess
pharmaceuticals.
getting to you on the phone might be the challenge.
Yeah, well,
But remember, you're handling appeals. So the first thing this guy heard was, no.
No, seriously, I think this is really important. And the question is, what drug would you want in your eyes? I ask you very personally, because that's what it is to me and my patient.
Right.
I'm looking at Miss Jones and I'm telling her, I got 3 drugs, and guess which one your insurance company wants me to use first? I use that line all the time because it's true. Because I've been kicked off plans. I've been audited multiple times. It's a frustration because the truth is, what drug do I want?
Well,
do I want the one that comes in a glass vial and has proven safety and efficacy, or do I want the one that's compounded and cheaper?
yeah, my answer to that would be, number one, tell me the difference in cost, because I have something called co-insurance where I pay 20% of the cost of the drug. And if a drug costs $2,000 a month, 20% of that is a lot different than 20% of a drug that costs $50 a month. And then I would say, what does the literature say? What do the large clinical comparative effectiveness trials say about the 3 drugs? And your answer would be?
Thank you for bringing that up. I have a
Would that how you
major
start
issue
the
with
answer?
that.
Why, thank you for bringing
So
that
just
up.
briefly, we have 2 major trials that compare them head-to-head. DRCR Protocol T in diabetes and CAT in AMD. There's others too, but those are the 2 biggies. So tell me, do you realize that there is a major difference in the bevacizumab that's used in both of those trials compared to the bevacizumab that I and Jared use every single day in practice? Did you know that?
I am not aware of that.
Did you know that?
I did not know that, no.
Then let me tell you what the difference is. Please, this is so important.
I
hope
am
you guys
so
fund the trial.
loving this broadcast.
Because, you know, the drug that was used in those trials came in a glass vial. And the drug that we use every day comes in a plastic syringe. And the difference is when you store a biological molecule in a plastic syringe, it degrades the quality goes down, published over and over in peer-reviewed manuscripts, that it's not reproducible and it's not as effective and it's not as safe.
So,
So
Charlie
we
and I
need
are-
comparative
yeah.
data that uses the drug that we use every day in practice. We don't have it, and yet we keep pointing, all of us, retina specialists too, we keep pointing to these trials that use a different form of bevacizumab than I use every day.
So Charlie and I are recently, our whole specialty was hit with repackaged bevacizumab that contained silicone oil droplets. And virtually every practice in the country was affected by this.
I'm assuming that's a bad thing.
Well, if you have permanent floaters in the center part of your vision that appeared after your injection and they're preventing you from seeing to do the things that you like to do, that's a horrible thing.
Okay.
And two, if it leads you to needing surgery later on, that is a horrible thing.
And is that a consequence of the compounding pharmacy?
Well, it's a consequence actually of the change in the manufacturing process of the syringe that was given to the compounding pharmacy.
I see.
And this was widespread. We all had patients that were affected by it. I've operated on patients that were affected by it. And so every time that we're having to use that, you know, you're thinking about this in the back of your mind. You're also thinking about the compounding pharmacy. What type of practices are they using to ensure to protect me? And while the cost of the bevacizumab is so much cheaper, it does not recognize the cost of these risks or the liability that my practice has to take on to use it.
Yeah, I would say if you're gonna, I actually am a believer that in many circumstances, bevacizumab, given our current economic and fiscal issues, is a reasonable first line. I really am. But please, will you put it in writing so that when there's a lawsuit, they come after you and not me?
Correct.
I mean it, because these conversations where we've been kicked off plans and we call them and sort of behind the bushes they tell us, well, the reason is you use too much on-label. It's just not right for practitioners across the country. Put it in writing, because that way we can stand behind it and actually support you.